Oh, good morning. We can start.
Okay, good morning, my teachers and colleagues. So today, Dr. John will be taking practice question 8. Okay, Dr. John, you have the floor and you have 10 minutes.
Good morning, my teachers, colleagues. I'm Dr. John Adams. I'll be taking practice question 8 of the 2023 October recall. The question says a 52-year-old man presented with shortness of breath on mild exertion. He developed cough productive of copious sputum, autopnea, paroxysmal nocturnal dyspnea, bilateral leg swelling. He had a history of severe lung infection in the past, and he was previously said to have asthma. Question A is describe what is shown in the pictogram. Mention 3 cardiopulmonary signs you will likely pick on examination. What are the possible differentials and likely diagnosis? What are the likely causes of this condition? This question D is not so clear to me. I was wondering if there was a mistake, if they meant causes, because I couldn't really find anything related to causes of this condition. What other investigation will you do? How will you manage this patient's condition? So the picture here is suggestive of and the history is suggestive of chronic obstructive pulmonary disease. And then this is a PA and lateral chest X-ray of the patient. And we can see the picture here does not suggest that this patient had heart failure, even though the symptoms could be in keeping with heart failure because of the autopnea and leg swelling. So the patient does not have congestive cardiac right and left heart failure, but this patient could have COPD with cor pulmonale. The COPD has been shown to also present with autopnea and then paroxysmal nocturnal dyspnea as well. So the lateral view here shows there is an increase in the retrosternal airspace filling. That's on the lateral view, the one on the right, the extreme right. And then there is also widening of the AP diameter on this chest X-ray. Why on the PA view there is hyperinflation because of the number of ribs that can be said to be happening here because of the number of ribs. We expect to see about the sixth rib cutting through the diaphragm, but in this case the patient has about 8 ribs before the diaphragm. And then there can also be enlargement of the central pulmonary arteries on this X-ray, and then flattening of the diaphragm. That's what I can see from the chest X-ray of this patient. Then mention 3 cardiopulmonary signs you likely pick on examination. Like I said, the patient likely has COPD complicated by cor pulmonale, and I also need to mention that possible bronchiectasis because of the copious sputum that this patient had. So in cor pulmonale, we will expect left parasternal heave, and then the third and fourth heart sounds could also be present in this patient. And then the systolic murmur of tricuspid regurgitation, splitting of the second heart sounds, and then diastolic pulmonary regurgitation could also be in this patient. The liver could be pulsatile because of tricuspid regurgitation, and this patient may have central cyanosis, crackles on chest examination, and then hyperresonance also of the lungs. So these are some cardiopulmonary signs that the patient may have. And then a likely diagnosis, like I mentioned earlier, could be COPD that is complicated by bronchiectasis and cor pulmonale. The possible differentials for this patient could be alpha-1 antitrypsin deficiency, which could be a cause of COPD. The patient may have cystic fibrosis. The patient may actually have asthma. Then restrictive cardiomyopathy and constrictive pericarditis, because the heart size of this patient appears normal, so it may not be suggestive of a congestive cardiac failure. So, like I mentioned earlier, also I couldn't really find anything related to causes. Maybe somebody may be able to help us later, or I may do further research to find how this relates to this question. So I thought maybe the question was referring to causes of the condition. So I looked for causes of COPD, which commonly is associated with cigarette smoking, occupational dust and chemical exposure, environmental tobacco smoking, which otherwise can be described as passive smoking, or indoor and outdoor air pollution, like we commonly have in our environment. Aging population is also a risk to COPD. Prematurity, mature birth, can also be a risk factor or a cause of COPD. And then what other investigations will you do for this patient apart from the chest X-ray? want to do a 2D and Doppler echocardiography because of the heart failure associated with this COPD, and then electrocardiography, and then to assess further of the core pulmonary. I would also want to do a cardiac magnetic resonance imaging, which is a non-invasive diagnostic measures for the core pulmonary. However, the gold standard, the diagnostics, is the right heart catheterization with pulmonary vasodilatation. And then I want to also want to assess the bronchiectasis with high resolution CT. And then abdominal ultrasound scan may also be relevant because this patient has leg swelling. You also want to rule out a kidney disease or liver pathology as well. Laboratory blood investigations could include brain natriuretic peptide, arterial blood gases. You want to do sputum culture because the patient has a copious sputum production. Assess the kidney with serum electrolyte, urea creatinine, hematocrit for polycythemia and COPD. Alpha-1 antitrypsin deficiency to also evaluate for differentials. Pulse oximetry will also be relevant in this patient management, and lung biopsy may also be indicated. And how will you manage this patient's condition? Sorry, I'm being fast because there's a lot I have to. So in the acute setting, you want to assess this patient's oxygen saturation. The patient who have poor oxygen saturation, SpO2 of less than 88%, you want to give this patient oxygen, but we have to be careful with that because you don't want to give the patient more oxygen and knock off the drive from the COPD. So you want to give that with a venturi mask, preferably with a venturi mask. And then medical therapy may also be indicated for the core pulmonary, which will be focused on the underlying pulmonary disease and then increasing the right ventricular contractility and then decreasing pulmonary vasoconstriction. Chest physiotherapy will also be useful in patients' management. Surgical treatment may also be indicated for. So for the medical therapy, by underlying addressing the underlying pulmonary disease, for COPD, you want to give bronchodilators. Steroid treatment may also be indicated. Bronchiectasis, you give mucolytics and antibiotics as well. And then to increase the right ventricular contractility, you want to reduce the preload by giving diuretics like furosemide, cardiac glycoside agents for inotropic support. And then to decrease the pulmonary vasoconstriction, calcium channel blockers may be relevant. Phosphodiesterase type 5 inhibitors like sildenafil may also be useful in the treatment of the patient. Patients who may not respond may require other interventional measures like cardiac resynchronization therapy or use of ICDs or valve replacement or repair. Surgical treatment may include transplantation. For severe cases, single lung transplantation, double lung, or the heart and lung transplantation may also be useful in management of the patient. So an overview of COPD and bronchiectasis in core pulmonary using this outline. COPD is a common preventable and treatable disease that's characterized by persistent respiratory symptoms and airflow limitation that is due to airway or alveolar abnormalities, usually caused by significant exposure to noxious particles. We currently have two phenotypes, the emphysema and the chronic bronchitis. The picture on the left is like a normal histology. You can see the alveoli surrounding the bronchioles and keeping it in place, keeping it patent. Now on the right, sorry, we now have destruction. Like in emphysema, what you have is destruction of this alveoli, and so you can see the destruction of the alveoli, and then that makes them lose the tensile strength they have on the bronchioles. So that can lead to collapsing of the bronchioles and then lead to obstruction of the airway. And in the chronic bronchitis, you have excess mucus in that airway. You can see the narrowing of the airway. This can also be worsened in bronchiectasis associated with COPD. So we commonly refer to them as the pink puff fathers, the emphysema, and the blue bloater. The COPD in 2012 was regarded as the sixth cause of deaths globally, and that risk has continued to increase. And 4 out of 5 COPD patients have comorbidities that is more commonly associated with cardiovascular diseases. Arterial hypertension has been seen in about 50% of those with COPD. So this is just a picture of some of the comorbidities that can be associated with COPD, and these are risk factors of COPD. I've mentioned some of them before. So in the pathophysiology of COPD, we know there is destruction destruction of the alveoli and narrowing of the airway, and that can lead to severe hypoxia. In severe hypoxia, the pulmonary vasculature attempts to increase pressure, increase blood pressure. So by doing so, it goes through some vascular remodeling, which further narrows the patency of those vessels, and then in the end, there's an increase in the pressure, the pulmonary arterial pressure, which usually will be 15 or below. But in pulmonary in COPD, because of the chronic hypoxia, that vascular remodeling eventually leads to a raise in the pressure in the pulmonary vessels that can go as high as 20, and then leading to pulmonary hypertension. Because when there is pulmonary hypertension, there is that pressure reflects in the right ventricle, and then the right ventricular walls also go through some remodeling, and then this also is reflected on the right atrium, and then eventually we have right-sided heart failure, which we refer to as cor pulmonale in this patient. So this is just a WHO classification of pulmonary hypertension. We have the one associated with COPD as in the group 3 of this classification. So cor pulmonale is defined as an alteration in the structure and function of the right ventricle of the heart caused by primary disorder of the respiratory system. And it can be acute, it can be chronic. Acute usually in severe pulmonary embolism, but chronic could be associated with COPD. It's been estimated in the US to account for about 6 to 7% of all types of adult heart diseases. And COPD is implicated in about 50% of these. Patients who have cor pulmonale and COPD have higher mortality compared to patients who have COPD alone. So bronchiectasis. Bronchiectasis is defined as abnormal dilatation of the proximal. So bronchiectasis can arise as a complication of COPD when there is when there is recurrent infections, and then the inflammatory process also leads to increased mucus production in the airway, and then can cause narrowing of the airway, which usually so there is weakening or destruction of the muscular and elastic components of the bronchial walls manifested by the airways, and are inflamed and easily collapsible. So the diagnosis is usually compatible with clinical history of the chronic respiratory symptoms such as daily cough and viscid sputum production. Bronchiectasis can be congenital or acquired, especially when there is a history of infectious insults, like in this patient. These are causes of bronchiectasis, and on the right are some of the likely organisms that could cause an exacerbation of COPD. In the diagnosis of this patient, we want to look at the history, like what our patient presented with the chronic breathlessness, autopnea, PND, right leg swelling, and then the history of exposure in this patient also, and then investigation that will be relevant in the management of this patient. So I've mentioned in the physical examination, you also want to look out for tachypnea, cyanosis, like I mentioned, the central cyanosis, wheezing, which usually will be respiratory, and then you want to assess this patient further because they may also have depression, so you want to assess their mental status as well. In the diagnosis of COPD, spirometry becomes relevant when you have an FEV1 over FVC that is less than 0.17, 0.7. So we can use the GOLD criteria in classifying this patient to mild, moderate, severe, and very severe.
Yeah, time.
Hello?
Please round up. Just your time is up.
Okay, so in the management of the patient, you want to assess, reduce risk factors, and manage stable states. And then, so I've mentioned oxygen therapy in the patient, and then in treatment of COPD, you want to give bronchodilators, like I mentioned earlier, and then antibiotics may also be indicated, like the use of amoxiclav and septrin. And then glucocorticoids have also been found to be useful in improving hospital stay in patients with COPD. Vaccination could also be useful in the treatment of patients with COPD. And then in conclusion, the burden of cardiovascular and comorbidity in obstructive airway disease is increasingly acknowledged, and there is a need to identify which patients are at increased risk to facilitate optimal treatment of prevention. Thank you.
Wow, thank you so much for that beautiful presentation. Okay, so now we'll take comments and questions from the participants first. Okay, so and let's keep the thanks coming on the chat. So Dr. Adescon is saying thanks. Dr. Ifoma is saying thanks so much, Chief. What supports COPD on the chest X-ray film? Okay, I think you mentioned some of them. Said hyperinflated lungs, flattening of the diaphragm. Okay. Dr. Johnson says, good morning, everyone. Good morning, teachers and colleagues. Thanks so much for a lovely presentation. Since we are attempting, can we consider the causes as follows? The cause and prognosis is undefined and may vary depending on several factors such as genetic predisposition, environmental risk factors, risk for acute exacerbation and vaccination status, rest of other comorbidities, step 5, adherence to lifestyle and environmental modifications. Okay, my thought on that, anyway, I stand to be corrected, but I think that should be cause and not cause, as I see AUSE. Dr. Binabe saying thank you for the presentation. Dr. Puta says thank you. Dr. Afolabi says thank you for the great presentation. Other important investigations in this patient include arterial blood gas measurements, pulse oximetry, and cardiac biomarker measurement. I think he mentioned that. Dr. Rita is saying thank you for the elaborate presentation. Then Dr. Irabotom says, what supported cor pulmonale on the chest X-ray? Sir, I think he also mentioned that. Okay, Dr. John, do you want to react on that?
Okay, so from the chest X-ray, I couldn't really make out anything that can support it except from the history.
Okay, so Dr. Adebimpe is saying, thank you for the beautiful presentation. Can the diagnosis be bronchiectasis complicated by cor pulmonale on background asthma, the history of previous infections? Okay, so based on the question, okay, let me just make some comments of my own. Okay, there's some hands up.
Hello. Sorry, you missed a comment.
Okay.
Or a question on the chat about antonisens. Okay. A comment from Dr. Success or a question. Just okay. Go back.
Okay. Let me go back. Okay. Okay, thanks for the presentation. What is Antonisen criteria? Okay, and she also added, what are the indications of L thoughts in COPD? Okay, Chief, do you want to make a comment on that?
I can't exactly remember what makes up the Antonisen criteria, so I may have to go back to that and post it on the platform, please.
Okay, let me just make a comment on the Antonisen criteria. The criteria that we used to classify exacerbation of COPD previously. So there are 3 components: the cough, sputum production, and shortness of breath. So if the patient does increased sputum production, if the patient has a 3, then it's severe. If the patient has 2, is mild, is moderate, and then the patient has just 1, is mild. But currently, the current guideline, we do no longer use the Antonisen criteria. There's now a classification of mild, moderate, severe with different components, symptoms, respiratory rate, heart. I'll post it on the group. So there's a current classification for exacerbation of COPD. Okay, I don't know whether I should make my comments first. Okay, let me allow these so many hands to talk first. Okay, Dr. Sori.
Yes, good morning, our chiefs and colleagues. Thank you very much for a very good presentation. Concerning the finding on the chest X-ray of COPD. So the lateral chest X-ray is very important. Okay, so in a normal person, when you do the lateral chest X-ray, you should be able to see the anterior border of the heart with a space between the sternum anteriorly and the anterior border of the heart. But when you have right ventricular enlargement, there is encroachment into that space. And as you can see from this chest X-ray, you cannot see that clear space between the sternum and the anterior border of the heart. So that suggests right ventricular enlargement. Okay, so it's encroachment into the retrosternal space. All right. And then, like you rightly mentioned, these findings of edema, dyspnea, they can be seen in patients with COPD without core pulmonary. Okay. And the pathophysiology behind that is that when you have hypoxia in COPD, the kidney will sense the hypoxia as reduced blood flow. And that can trigger the renin-angiotensin-aldosterone system and cause fluid retention and edema. So some patients can present with all this edema finding and edema without core pulmonary. But in this case, the X-ray is actually showing right ventricular enlargement, which supports the diagnosis of core pulmonary. Okay. Then there's further interventions they mentioned, like resynchronization. I didn't quite get that part of the presentation. I think he went through it very fast. You go to the other management for the core pulmonary. There are some things that are not clear that you mentioned in that part of the presentation. If you can just comment on those ones. Thank you.
Thank you very much for your comments. So the resynchronization therapy may be relevant because of the core pulmonary. Patients with core pulmonary, just like every other hypertensive heart failure, may come down with arrhythmias, and that may actually require some electrophysiologic intervention in the patient.
Okay, sorry, Dr. Justice, are you okay with that? Sorry, Dr. Suri.
Well, you know, for resynchronization therapy, there are specific indications for that. And usually you do resynchronization therapy to improve, you know, left heart systolic function. Okay, and you must have an ejection fraction less than 35 before you consider resynchronization therapy. And then when you look at the guidelines for resynchronization therapy, you know, it has not been shown to have much benefit when you have right bundle branch block. Okay, and in people with COPD, what you expect there is right bundle branch block. Okay. And looking at literature, I've not seen, you know, the use of resynchronization for patients with, like in this one, isolated right heart failure. Because you see the chest X-ray is not showing cardiomegaly. The left side is, when you look at the AP, the left side is fine, okay? But in the lateral, you only see right ventricular enlargement. So without involvement of the left heart, without reduced ejection fraction demonstrable, resynchronization therapy based on guidelines, you know, is not indicated.
Thank you so much. Thank you so much. Okay, Dr. Ojo.
Yeah, thank you very much for the presenter for the presentation. Good morning, my teachers. My comment is, sorry, I don't know if you can go to the slide. It has talked about the signs to really sick in the patient. Just to make some comments. Okay, yeah. Yes, thank you. Yes. Yes. The third and fourth accent, I'm not sure, is it on the right side or the left side? Because we know the common causes of the third and fourth accent, core pulmonary, then the core pulmonary causing the third and fourth accent. I'm not really sure. Then, yes, you have mentioned the accentuation of the pulmonary components and also the sign of hyperresonance, loss of cardiac and hepatic dullness. Now, talking about the right heart catheterization that you mentioned, yes, you are right by saying that it's a gold standard. It's actually important to, the usefulness is one to make diagnosis of the pulmonary hypertension. It's also very important to know what type of pulmonary hypertension we are dealing with. Is this the pre-capillary type? Is it the post-capillary type? Is it the mixed picture? And it's also important to know that during this procedure that you do your vasodilator test. And it's the result of the vasodilator test that will determine which of the medications we have mentioned that the patient can benefit from. So if a patient will respond to vasodilator test, for example, that kind of patient will do well on vasodilators like the nitrates and the sildenafils and co that you mentioned. But if they fail to respond, then you have to go to other group of drugs. So the right acquisition is very important to make diagnosis, to know the type, and also to know the type of medication to use for the patient. Thank you.
Thank you so much, Dr. Ojo. Dr. Kalamama.
Okay, thank you so much, Dr. John, for that brilliant presentation. Okay, I don't know if you can just go back to the question. I just want to make an add-on. Okay, so here they said the patient, he was previously said to have asthma. Okay, so I'm just thinking aloud, like in the diagnosis, can we actually say this patient has bronchiectasis secondary to asthma COPD overlap, and maybe probably complicated with maybe pulmonale or heart failure? Okay, the reason why I'm saying this is because I know bronchiectasis doesn't really cause hyperinflated lungs, so as asthma doesn't cause that. And they didn't give us a picture of the patient having COPD, which may have been missed. So, and then the chest radiograph is actually giving us a picture of a patient with COPD. So thinking aloud, since they said the patient has asthma, could it be that the patient has an overlap, having asthma COPD overlap? Could it be the cause? Because I know asthma COPD can actually cause bronchiectasis, which can present with copious sputum. Then also, I want to make an add-on to the chest radiograph finding. You know, basically in COPD, we have is it tubular shaped or a cylindrical shaped heart in COPD due to the hyperinflated lungs. You know, from the hyperinflated lungs, it pushes the heart into the center and makes it look tubular, makes it look cylindrical. But in this case, the heart doesn't look cylindrical. Maybe basically because of maybe the heart failure, which is the background heart failure that is ongoing. So that's why the patient did not have that picture of that narrowed or that cylindrical shaped heart. So that's just my thoughts about that. Maybe because of the background heart failure, though it did not really show the prominent left ventricular hypertrophy. Although Dr. Conte just talked about something else we can see at the lateral aspect of the radiograph, where you see the anterior border encroaching into the retrosternal space. So I think maybe that's the reason why that heart is not looking cylindrically shaped as it should be, because there's a background heart failure thing ongoing in that patient. Then an add-on to the signs, just like the normal bedside examination for a patient who has a COPD, you will notice that the patient has a barrel-shaped chest. And then when you do your simple tactile fremitus and vocal resonance, it's reduced because of the air that is so much, like it actually reduces the tactile fremitus and the vocal resonance. So that can be an add-on to the signs there for this patient. Then also, I can remember then when a patient has exacerbation of COPD, hope I'm not wrong, I think the pulmonologist will correct me. There's something about the cricothyroid space that is being shortened. That in quotes, if the patient actually has an exacerbated COPD, where we can also see copious sputum. So I don't know if that can be an add-on to the signs there. Then for the differential diagnosis, I think maybe I want to add on pneumothorax because of the hyperlucency of the lungs in this patient. So I think that's basically what I want to add on to what he has said. But I stand to be corrected. Thank you so much, Dr. John, once more for a beautiful presentation.
Thank you, Dr. Florence.
Oh, thank you so much, Dr. Florence, for that addition. Okay, let me just make a few comments. I think we still have some more chats on the chat box. Okay, for the diagnosis, my own thought, I think it would just be safe to say bronchiectasis with heart failure, because you said the patient has asthma, even if the X-ray picture that is shown shows features of COPD. Because I think because even the bronchiectasis can also cause pulmonary hypertension that will lead to cor pulmonale. So I think it will be safer to say our main diagnosis is bronchiectasis, and then with cor pulmonale, maybe background asthma or COPD. But for a patient that is so symptomatic, you may not want to do spirometry, to confirm whether it's asthma or COPD. But the chest X-ray findings are kind of suggestive of COPD. So because COPD, asthma, they can also cause bronchiectasis. So I think the main thing here from the question is the bronchiectasis, because it can also lead to heart failure. Then for your investigations, I don't think a lung biopsy will be necessary here, because you can make your diagnosis with the other investigations you listed, like the echo, very important, because even if this patient has a lung pathology that can lead to pulmonary, he's 52, he's also entitled to other causes of heart failure. So the echo is very important, echo and ECG is also very important. Then to add, so you can also do, for a patient with bronchiectasis, it would be good to do immunoglobulin assay as one of the investigations, and then aspergillus precipitans. And then the ABG you mentioned is also very important, because if it's actually COPD, patient may have background mild chronic hypercapnia, which will now make you be careful with your oxygen therapy. Then to the management, I think it would be nice to mention that the patient should have a multidisciplinary team approach management, because he has a lung pathology and then suspected heart failure, even if, just like Dr. Conte said, the COPD could also cause those symptoms. So the cardiologist should involve radiologists, the physiotherapists, because for the bronchiectasis, you need to do chest physiotherapy. You may need chest physiotherapy to mobilize the sputum, then your culture, and then the antibiotics. Okay. Then your inhaler technique is very important. Pulmonary rehabilitation. Okay, so let me just take a few more comments on the chat, and then we'll move to our teachers. Okay, I think Dr. Success was asking for indications for L-TOT. I don't know if you want to comment on that.
Indication for what?
Okay. Long-term oxygen therapy. Then, okay, maybe we put that on the chat. Then thank you for the presentation. From the history, can it be bronchiectasis complicated by heart failure? Okay, we just talked about that. If we want to incorporate the findings on the chest X-ray, can it be overlap? COPD bronchiectasis syndrome. Okay, pulmonary, I think it's an echo findings, not a clinical diagnosis. So that's from Dr. Atta. Then Dr. Yahaya Mohammed says, thanks for the good presentation. Maybe this X-ray was not similar to the X-ray that was brought during the exam. The X-ray given might be clear to support the most likely diagnosis. And then Dr. Jamila is saying, thank you for the beautiful presentation. Please, can pulmonologists comment on tram, I think you want to say tram track sign and ring sign on the X-ray. Is it normally seen on X-ray? Yes, you can actually see that, but it's very difficult. So for bronchiectasis, the gold standard is your high resolution CT scan. You can actually, if it's very obvious, sometimes you can see it on the chest X-ray, the tram track. That's the dilated, abnormally, irreversibly dilated bronchi. You can actually see it on chest X-ray, but the gold standard would be your high resolution CT. It will delineate it better and to be clearer. Okay. Okay, then you also mentioned when you were talking about the treatment for the pulmonary hypertension, you mentioned the phosphodiesterase 5 inhibitors. So if the patient actually has COPD, if it's confirmed, you want to really downplay the use of phosphodiesterase 5 inhibitors. Most times, they'll say just use, focus on the L-TOTs. That's the long-term oxygen therapy. It will help. Okay, thank you so much, everyone. Mark, I don't know. I think we can take comments from our teachers now. Mark Christabel.
Mamodu's hand was up earlier. I don't know if he's done speaking. Because it's done now. But Mamodu.
Thank you so much, man.
Okay.
Sorry, I initially got out of time. I said, okay, thank you so much. The X-ray, sorry, please. I don't know if you can just go back to that X-ray, please. Because the question here, most times we try to just oppose our clinical findings and radiological findings. If you look at this X-ray very well, from the first outlook, it's actually a poor X-ray and a poor film, but that does not mean we can't delineate some of the pathologies within it. Asthma COPD can cause hyperinflated lungs. In this picture, this typically depicts that with the hyperinflated lungs, as evidenced by this You see the transverse nature of the ribs in terms of alignment. Look at the diaphragm; they're actually quite flattened. Okay, so it's quite important here. The main thing is this question gave us some very important things that we should not overlook. Although they are not basically depicted here in this, what they call it now, X-ray. But we have to join our clinical, most especially our clinical suspicion too, of which we know the radiology is supposed to help us actually potentiate, or investigation help us potentiate that. But that was not in keeping here. We don't know about this X-ray if it fits perfectly into this situation. But the only thing here is just as he has put signs of hyperinflation. Then also we could see the increased anterior-posterior diameter. In asthma, even the hyperinflated lung, you can have the retrosternal space widening or open. Here it's actually narrowed, reduced. So I think I go with Dr. Ekele talking about the bronchiectasis, which is given in that question there of the recurrent chest infection, of which this patient might have had a background asthma, okay, which showing the hyperinflation or COPD. But as we said, previously had been said to have asthma. Although we also know, if we look at it from the general angle, we can easily put it. But within the pulmonology specialty, there are asthma mimics, okay, that may make someone think, okay, yes, this patient is having asthma, of which you want to make some confirmatory tests to diagnose whether this is asthma or this is COPD. As we know, spirometry can help us, where we see a reversal of the airway limitation. For COPD, it's not reversible. But one thing I want to point here is so that we don't get carried away with the chest X-ray. This patient has had recurrent infections with the likelihood of having a bronchiectasis. Typically, you should also take no cognizance a phenotype of COPD, chronic bronchitis. If you had been having continuous cough for the past 3 months, over the last 2 years, that a diagnosis of chronic bronchitis is quite clinical. You don't even need, just only on those things, you'll be able to make that diagnosis. It's quite clinical. So it's very important we don't want to crowd more things. I don't think they want you to say an asthma COPD overlap. This patient obviously has enough clinical reasons to say, yes, he has bronchiectasis. And then we are seeing signs of both right-sided heart failure and left-sided heart failure. I thought we saw PND in that place. The core pulmonary can progress from the right heart-sided failure to involve both hearts. So typically depicting, or how do I put it now, making this picture a bit in that same light for the lateral view. And then the anterior-posterior diameter, if you can see it, if you see the normal X-rays, it's not, if you look at the chest wall, anterior chest wall, it looks protruded away from the normal, what do you call it now, architecture of the chest. It's like there's the barrel shape or increased anterior-posterior diameter, which favors that this has some chronicity, and this would have moved into a biventricular heart failure, if possible. So bronchiectasis with heart failure is actually very, very appropriate for this diagnosis. We can't see any tract appearance here. We can't see any of the cystic dilatations here. We also, that's, I don't know, maybe because of the X-ray, okay? Then also we should be very careful of something. There's what we call the anode effect on X-ray. You see a particular part of the X-ray, hyperlucent, and you see as it goes away from that particular side, it becomes much more duller or hazy, you understand? It's actually an anode defect. It's a radiological error, whereby you now look at the parts that are closer to the anode as hyperlucent, thinking or mimicking a pneumothorax. That's actually wrong. So that's why it's very crucial and very important when we are saying for disease conditions to look at the X-ray very, very well, critically, to show that there are no errors in that X-ray before we make some of our diagnosis or conclusion. Thank you.
Oh, thank you so much, Mr.
Thank you
I
very
think
much.
the press hand was also up. I think she's a pulmonologist. So
Yes, ma.
let us speak so that we can move to the next question.
All right, good morning, teachers and everyone. I've put some of my comments on the chat. I agree with Dr. Momodu, what he just said. So let's remember that this is a recall. I mean, the X-ray that was presented in the exam may have been more clearer than this, but the history is very important. Usually, for COPD, they will likely give pointers in the history for possible risk factor, maybe smoking or something, occupation. But in this particular history, what they gave was that the patient had a past history of a severe infection. So that's key. So basically, that points more likely to bronchiectasis. Then them saying he was said to have asthma in the history is actually a pointer. So a lot of times people think they have asthma, it's actually not really diagnosed. So it doesn't mean we have to take it as the patient had asthma before. So most likely they are just still trying to say that most likely this patient had the background bronchiectasis now being complicated with pulmonary. So the other important thing to consider, especially in our environment, and then them saying he had a past serious lung infection is a post-TB lung disease, which could also give the person chronic symptoms, which they thought was asthma, and they're now presenting with pulmonary. So those are the things I just wanted to add. So that's an important differential to add here as well. Thank you.
Thank you.
Thank you so much. Thank you, Dr. Temitope. Thank you. I don't know if our teachers have any comment. If Remedios Chitu, Cookie, Jabansi, any comment, please?
Doctor, thank you, Doctor. Yeah, thank you, Dr. Christabel. Well, I think this question is actually not straightforward, but I think the most important information is that asthma, that background history of asthma. I think that should be really looked at. So, and I agree with the pulmonologist, because of that background history of asthma, one should tilt more towards bronchiectasis than COPD. Okay, so that information, I think, was the key giveaway in the question. And please always remember that the exams are not supposed to confuse you. They usually give you tips to make you realize that this is the most likely problem. Okay, so don't ignore those tips. That background history of asthma there, I think, was the tipping point, and then one should not ignore it. In fact, I was even starting to think about asthma and bronchiectasis, thinking about things like allergic bronchopulmonary aspergillosis, but I realized that they didn't give enough information to go for that. So I think I agree with the pulmonologists. And sometimes maybe the recall might not be so perfect and it may affect the question. I think that might have happened here. Or maybe even the X-ray that he got might have confused the whole thing. It's also possible that the whole information is on the X-ray. Okay, so let's not overflog it. The presenter did a very good job, and I love the contribution so far. So the important thing is for us to have a wide we should just have an open mind, whichever way it comes. Let's not forget that there are important tips in the questions, and we should not ignore them. Thank you.
Thank you so much, sir. I appreciate you, sir. So, Dr. John, thank you so much for a wonderful presentation. I must really commend the pulmonologists, Dr. Ekele, Dr. Mamudu, Dr. Temitope, and every other person that contributed. Thank you. You made it more interesting, and there are a lot of learning points. I don't really have anything to add because from all the discussions already, be quite extensive. So thank you so much. Dr. Ekele, I think we should try and take the second question. We don't have so much time. Let's see if we can finish it before closing time.
All right,
That should be Dr. Kuma,
right? Yes, ma'am.
Okay.
Yes, ma'am. Okay, Dr. Kumo.
Okay, good morning, everyone. Let me share my slide. Okay, good morning, our teachers and facilitators and our colleagues. I'll be taking the practice question 10. And I'll read the question. It's a 35-year-old woman who presented with weakness and malaise. She is hypertensive, but the blood pressure is controlled. A kidney biopsy was done. Results reveal membranous nephropathy with features of class 5 lupus nephritis. There was no proteinuria on the urinalysis done. Other lab results were essentially normal. She's currently on immunosuppressives, methotrexate, and cyclophosphamide, which was changed to mycophenolate mofetil. So the questions are, list other investigations you would want to do. What advice or counseling would you give in terms of medications and conception, renal disease and outcome? And then additional history says she later became pregnant. What complications do you anticipate in this patient? How would you continue to monitor her? So in answering the first question, already she's had one of the most important investigations to do in a patient who has lupus, and that's the urinalysis. And she's also had a kidney biopsy. So the other investigations I would like to do is to quantify the proteinuria, doing a urine albumin creatinine ratio or urine protein creatinine ratio. Also, a 24-hour protein excretion is also important and can be helpful. Serum electrolytes, urea creatinine is also important here. Total protein and albumin would also be useful here because a lot of them would have some degree of hypoalbuminemia. Full blood count ESR, C-reactive protein. The serologies are very key because it would show the hypocomplementemia that most of the patients have. And then other antibodies would be important to look at, especially considering the fact that they told us she's pregnant. Some of the key antibodies to look out for the anti-LA and anti-Ro antibodies, because if either of them is positive, the risk of the fetus having some congenital heart defect is also very high. So it's important to also look out for other antibodies. And then renal ultrasound would also be helpful to rule out hydronephrosis or some other obstructive nephropathy. So the question 2 says, what advice would I give or counsel as regards medication and conception? And then what will I tell her concerning renal disease and outcome? So in regards to the medication and conception, my counsel for her would be to let her know that pregnancy may affect the course of lupus nephritis, and lupus nephritis and the medications we use to treat lupus can also influence the outcome of the pregnancy. I'd also advise her that for women who are of childbearing age who have lupus, ideally they should be in active disease for at least 6 months before attempting to conceive. This is just to avoid renal flares during pregnancy and postpartum. I'd also let her know that she's been on methotrexate and cyclophosphamide already, but I would have to discontinue them. Ideally, they should have been discontinued 3 months before she even took in. Also, the medication she was replaced on, that's the mycophenolate mofetil, is teratogenic. It can cause microtia, micronatia, hypoplastic nails, cleft lip and palate, congenital heart defects. And I would have to stop that. I would let her know that I would have to stop it, although this should have been stopped 6 weeks before her conception. And I would let her know that I'll be switching her to something safer, considering that she's pregnant, and that will be azathioprine. And also, I may place her on hydroxychloroquine. The azathioprine and hydroxychloroquine are reasonably safe during pregnancy, and HCQ is very important to avoid flare of lupus and to prevent preeclampsia, which is one of the complications that I would anticipate in this patient. Some medications that are safe in pregnancy are corticosteroids, which I might place her on in the course of the pregnancy. So I'll let her know that that's a drug that I might place her on, but assure her that it's actually safe. And even if I have to place her on it, I'll place her on very low dose, less than 20 milligrams per day. And then cyclosporine and tacrolimus are also not teratogenic. They are considered safe, although they have increased risk for GDM and elevated blood pressure, especially the tacrolimus. And then I'd also let her know that if at all she's considering taking in next time, she should start to consider fertility preservation methods like use of the gonadotropin releasing hormone analogs and oocyte cytopreservation, because cyclophosphamide causes premature ovarian failure and menstrual irregularities. And I'll counsel her on the use of contraceptives. IUCD is one of them, and progesterone-only contraceptives while she's on cyclophosphamide or methotrexate. Then my counsel for her on renal disease and outcome would be that lupus nephritis is one of the most severe complications of SLE. Early detection and treatment can significantly improve the renal outcome. Some predictors of poor obstetric outcome would be patients who have active disease pre-pregnancy, baseline poor renal function, and patients who have presence of antiphospholipid syndrome or hypertension. And I'd let her know that despite the fact that she's it appears as though there are absence of symptoms at the moment, but I'll still keep screening her for proteinuria and hematuria every 3 months. The proteinuria and the serum albumin creatinine are very key biomarkers of renal outcome in lupus nephritis. And the proteinuria cutoff, what I expect is to have levels that are less than 0.5 to 0.7 gram per day at 12 months from the initiation of the treatment. And then I'm also aiming for a serum albumin of greater than 3.7 gram per deciliter at the same time. This actually predicts favorable renal outcome. The answer for the question 3 is what complication, well, the question is what complications do I anticipate in this patient? One of the key complications I'll be looking out for is lupus nephritis flares. And then thromboembolic phenomenon, preeclampsia is a very common complication that patients who have SLE pregnancies can have. Dyslipidemia, I would anticipate that. Nephrotic syndrome, preterm delivery, miscarriage, and intrauterine growth restrictions are also some of the complications I'll be looking out for. The 4th question says, how would I continue to monitor her? A multidisciplinary approach will be instituted involving the nephrologist, obstetrician, and the rheumatologist. And what I'll be aiming for is a chance of successful pregnancy and to minimize the risk to both the mother and the baby. Important for me is to be able to profile her based on the risk factors. And she can belong to either of these groups, either inactive quiescent lupus nephritis, active lupus nephritis, or lupus nephritis with severe organ dysfunction and or pre-existing severe organ damage. But based on the features that they had given to us from the question, she appears to be in an inactive phase of the lupus. So I'll continue to monitor disease activity, doing full blood count, renal function every 4 to 6 weeks. And I'll be doing urinalysis and urine protein quantification every 2 to 4 weeks based on the level of the proteinuria. Also, irregular maternal and fetal surveillance, ultrasound surveillance would be important for her. During the first trimester, I'll be checking the fetus from anything from 11 to 14 weeks. In the second trimester, 20 to 24 weeks. And then when she gets to the 3rd trimester, every month between 28 to 34 weeks, I'll be doing a surveillance. And then once she gets to 34 weeks is to do the surveillance weekly. And then also monitor her for tolerance. Since I changed her from her previous immunosuppressives to azathioprine and HCQ, I want to see how well she's tolerating the medications. In the event that she develops blood pressure rise, I'll consider pregnancy-safe medications like labetalol, nifedipine, and methyldopa for her. Prophylactic therapy against preeclampsia will be very important for her. So I'll give her, what's recommended is to give low-dose aspirin, less than 100 milligram daily. In a lot of the articles, they actually specify 81 milligram per day. And also calcium supplements will be important too for her, if at all I do place her on the steroids because of fear of osteoporosis. So that's the answer to the questions we have. My slides, which I'll be running through, I was able to do that with the help of Prof. Oviasu's slides and Dr. Juliet Amadi's slides. So I'll just run through the slides, going through this outline. So by way of introduction, SLE is a chronic multisystemic autoimmune disease in which organs, cells undergo damage from tissue-binding autoantibodies and immune complexes, and it affects a lot of organs: the skin, joint, lungs, the heart, serous membranes, nervous system, and especially the kidneys. And is most prevalent in women of childbearing age, although more aggressive in men. And the kidney injury. Okay. So lupus nephritis may be the first presentation in patients who have SLE. This is just a table just reminding us of the criteria for SLE. When we come to SLE and pregnancy, SLE pregnancies are associated with increased incidence of disease flare as well as adverse pregnancy outcomes. And it's important to look out for complications that we had mentioned earlier. About 20% of lupus pregnancies are complicated by preeclampsia, and a multidisciplinary approach is important when it comes to managing them from preconception to the delivery. This is just a table helping us to appreciate the differences between SLE flare and preeclampsia, and then a table showing us the medications that are said to be safe in pregnancy and even in lactation. Just a few definition of terms. When we see a patient has active lupus nephritis, is because there's a presence of active urinary sediment and or protein greater than 0.5 gram per day, with or without increase in the serum creatinine. And then if it's inactive or quiescent, the proteinuria is less than 0.5 gram per day, and they have inactive urinary sediment. So I think I'll just leave so regards to the etiology, most of them are idiopathic. Genetic factors are considered, immunologic factors, environmental factors as well. The genetic factors, one of the important aspects is the HLA-DQ locus, which has been linked to produce double-stranded DNA, as well as anti-Smith and anti-phospholipid syndrome. And these are just other genetic factors that have been implicated. Then when it comes to the immunologic factors, for patients who have SLE, it's known that they have poor clearance of cellular debris, and these cellular debris are able to activate interferon alpha, cause a lot of production of interferon alpha, which is known to be a potent inducer of immune system and autoimmunity. At the same time, it also activates autoreactive B lymphocytes, and this leads to production of a lot of autoantibodies that we see in patients who have SLE. The environmental factors are drugs like hydralazine, isoniazid, methyldopaquinidine, also ultraviolet light, Epstein-Barr virus, smoking, alcohol, silica dust, and then importantly, sex hormones and OCPs have been implicated. I think I'll leave the pathogenesis. So the histologic classification, this is important because according to the International Society for Nephrology and the Renal Pathology Society, the classification is based on the location of the immune complexes. We can find them in the glomeruli, and then also presence or absence of endocapillary proliferations is important. And wants to know the extent of glomerular involvement. Is it just focal or is it diffuse? And then are we dealing with an active disease state or a chronic disease state? So this is just a table showing us the classes of lupus nephritis. And then our patients who had the class 5, the membranous type, what we see in class 5 is numerous subepithelial deposits in greater than 50% of glomerular capillaries with thickening of the glomerular basement membrane. Clinical features: hypertension, peripheral edema, frothy urine, polyuria, nocturia, co-colored urine. And then for patients who have significant peripheral edema, it's seen especially in patients who have diffuse or membranous lupus nephritis. So this is just a picture showing us an overview of the clinical manifestations, and then investigations, just as we had mentioned, is the urinalysis to quantify the proteinuria, do their metabolic panel, the full blood count ESR, C-reactive protein, ultrasound, and then the biopsy. So biopsy is still gold standard, and the indication for doing biopsy is when we have a protein excretion of greater than 500 milligram per day, or if the patient has decreased GFR, irrespective of the level of proteinuria. So this is just a flow chart of how we go about with the kidney biopsy. And then the treatment. Treatment depends on the histologic class, the disease severity, and as well the risk for disease progression. So for patients who have non-proliferative forms, that's the class 2 and 5, we manage them conservatively. While in classes 3 and 4, which are known as the proliferative classes, we use immunosuppressives and steroids. Class 4 is treated using renal replacement therapy. The phases of treatment are the induction phase and the maintenance phase. So for want of time, these are just slides showing us what the induction phase is done for 3 to 6 months, but the maintenance phase can go as long as years. But when it gets to the maintenance phase, we taper down the drugs a bit, but we keep giving and watching out for flares, just so that we don't reduce so much and make them predisposed to developing flares. The treatment goal is to aim for proteinuria of 0.5 to 0.7 gram per day or less by month 12 from the baseline, and then also to control extrarenal disease. Other medications that we can use, as I'd mentioned, tacrolimus, cyclosporine, rituximab, belimumab, but currently, because of the involvement of interferon alpha, we're now looking at anti-cytokine therapies in managing patients who have SLE and lupus nephritis. So in regards to prognosis, renal disease is one of the main causes of death in SLE. The prognosis is really good if the immunosuppressives are introduced early. And then 5 to 20% of lupus nephritis patients develop end-stage renal disease within 10 years from the time we diagnose lupus. So class 1 and 2 have the best prognosis, while class 4 is said to have the worst prognosis. These are other adverse prognostic factors that we can look at. Thank you for listening.
Thank you so much, Dr. Thelma, for that beautiful presentation. So we'll take comments from the participants first of all. Why am I echoing? I don't know. I wasn't there before.
Somebody had two devices on, and both of them have volume. So please, they should switch off one, please. I think the presenter, please, or the person that like. Just switch off one. Just switch off the audio on one.
Oh, thank you so much, sir. Okay, so we have a lot of thanks to you, Dr. Thelma, on the chat, and then Dr. Florence, please go ahead.
Okay, thank you so much, Dr. Thelma, for that detailed presentation. You were really very fluent. Okay. So I was thinking that the stage 5 had the best prognosis, because you were mentioning 1 and 2, because I know that stage 5 normally has preserved renal function, and then also the proteinuria is actually of sub-nephrotic range. Then again, as you said, for the ones with the better prognosis, you can just treat them with normal, maybe renin, angiotensin, aldosterone antagonists, that's like the ARBs or ACIs. Then again, in managing these patients, since she actually is in the stage 5, we can actually allay her anxiety, telling her that this is not like the bad prognosis, this is like a good prognosis, and then can be treated with just medications like the RAS antagonist. Then also, when I was going through lupus nephritis, they also mentioned that stage 3 and 4 actually have the worst prognosis, especially stage 4. Why being because there's like an irreversible damage to the kidneys, and then they also have nephrotic range of proteinuria, because how you will tell the prognosis in a patient with lupus nephritis is from the level of protein being found in the urine, and also the level of damage to the kidneys. So to add on to her management, we can actually allay her anxiety, telling her that it's actually a good prognosis. Thank you. So that's all what I have to add to you. Thank you so much, Dr. Thelma. You did a great job.
Okay.
Thank you so much, Dr. Florence. Dr. Thelma, do you want to react to the best prognosis?
Okay, thank you so much, Dr. Florence. I completely agree with you. Really, the classes with the good prognosis are actually 1, 2, and 5. But for some reason, I think that's the last slide I shared, just highlighted just 1 and 2. But really, it's actually 1, 2, and 5. And then 3 and 4 are the ones with the worst prognosis. And really, with regards to allaying her anxiety, that's very important, just so that she doesn't think that it's the worst situation that she has. So I completely agree with your contributions. Thank you so much.
Okay, I think Dr. Yahya is also reacting to what you said, Dr. Florence. He's saying that he just dropped on the chart, ACIs, ARBs are relatively contraindicated in the setting of pregnancy. I think he was reacting. It's what I said. And then also to add to that, I had a similar question. In the slide you said for stage 5 you treat conservatively, but for those patients you manage with azathioprine and hydroxychloroquine. Is it because she's pregnant? She was in stage 5.
Okay, but when I looked at the question, she was already placed on immunosuppressives, the methotrexate and cyclophosphamide. So I was just wondering, maybe the nephrologist actually helped me, but I just didn't think, okay, should I take her completely off what she was on or place her on something that is mild and would still kind of, shield her from developing lupus nephritis flares? So that was why I thought to add the azathioprine and possibly the HCQ to prevent preeclampsia, but I stand to be corrected on that.
All right. Okay, so Dr. Yahaya Mohammed is also adding that serial fetal echo will also be helpful. Even if she, I guess he wants to say does not have anti-Ro
and anti.
Okay, and others are saying thank you. Dr. Wiki is saying thank you. Dr. Momodu, Dr. Temitope, they're all saying thank you so much. Okay, so at this point, let me see. Any hands up? Okay, Dr. Abdul Kari.
Chief Chitu, your hand is up. Please go ahead.
I know. Most people get shocked that my name is Abdul Karim, but yeah, that's my name.
Yeah.
All right. All right. Yeah. So well done to the speaker. You've spoken well. But I want to ask, have you seen a patient with stage 5 lupus nephritis being managed?
No, sir, I haven't.
Okay. Because you sounded like, yes, it sounded like a textbook, actually. But it's in keeping with the fact that you haven't seen one managed before, and that may cause one or two things. Now, in lupus nephritis, one thing we're very afraid of generally is them getting pregnant. Okay. Now, you've pointed out that stage 3 and stage 4 have the worst prognosis, yes, because those are the ones that can cause rapid deterioration in renal function and, of course, kidney failure altogether. Okay. Now, 1, 2, and 5 are said to have the best prognosis. Why? Because there is no active disease, what we call active disease, meaning the person is not spilling blood, the person does not have signs of acute inflammation going on in the kidneys. Okay. But we do have to note that stage 5 is only a step away from stage 6, which is the advanced sclerosing and all of that. And basically the end of the spectrum. All right. Now, this patient is pregnant, yes, but we also have to keep in view that you don't want this patient to progress. Even though it has good prognosis, you don't want them to progress. And if you read it up and you see the hallmark of management of stage 1, 2, and stage 5 is to reduce the chances of progression. And the key thing you're trying to do to prevent that progression is adjusting the blood pressure or reducing the blood pressure and preventing proteinuria. Now, if she's pregnant, most of the drugs that will help her reduce protein loss, which are the ACIs and the ARB and all of that, cannot be given to her. All right. And of course, we do know that membranous nephropathy, whether primary or secondary in the case of lupus nephritis, is very difficult to treat because many a time they do not respond to treatment. And you now add to the mix that she is pregnant again. So yes, it's good to say all the ideal things, but at the same time, you also have to pitch in the fact that, look, this, even though it's a membranous form, it's still an advanced stage of disease in patients with lupus nephritis. And whether you like it or not, that pregnancy is going to impact the disease and may make the person even progress to the 6th stage. Okay, because while the person is pregnant, you can't use those medications to stop proteinuria. You're going to have difficulty controlling the blood pressure, or she may develop preeclampsia that may make it worse. Okay, and then you can't even give her most of the immunosuppressives that don't even work in someone that is not pregnant normally. Okay, so you're not going to give her things, you're going to take away drugs because you can't give anything beyond steroids, azathioprine, and maybe hydroxychloroquine. That's the only thing you may be able to give her while she's pregnant. So another thing you have to pitch inside here is the possibility that does she want to keep the child? Because termination of the pregnancy is a possibility here. Because when you look at the pros and the cons, if she already has a lot of children already, and she's not really bothered about having an extra one, or she's not pressed to have an extra child, then that's another possibility you have to throw into the mix, because the fact that she's pregnant, she may just progress to the final stage and game over. Do you understand? So yes, everything you said is correct on the bottom, yes, but you also have to put that into consideration if you are managing the patient, because that is a possibility. You may end up losing the patient because of that pregnancy. And as many of the nephrologists here will tell us, Dr. Remigos, I'm sure he has seen it, many of our lupus nephritis patients, what ends up killing them is getting pregnant. I've seen it not once, not twice, multiple times. You are controlled, they get pregnant, everything goes bad. Okay, so you want to avoid them getting pregnant in the first place, but when you can't, you take that into consideration. Then another thing we're trying to bring out in this question is the fact that many of those drugs are not safe in pregnancy. MMF is not safe in pregnancy. Cyclophosphamide is not safe in pregnancy. Okay, the calcineurin inhibitors, out of the way. So you start having to limit yourself to certain drugs that don't tend to control disease, because membranous is the most difficult of all of them to control with immunosuppressives. Then you now add the situation where you can't use all of them. In fact, some people go to rituximab in patients that have stage 5 disease. Okay, people go that far because it may not respond to other immunosuppressives. So you have to take that into consideration. So in summary, what I'm trying to say is, one, you have to look at it in the picture of what is written in the textbook, like the presenter has done perfectly well. Two, you have to look into the context of what are you trying to do in someone with stage 5 disease, and that is prevent progression. So ACIs, ARBs have to come to the mix, but you can't give it to someone that is pregnant. Okay? Then you have to consider the fact that the pregnancy is going to impact your management, of which we had mentioned earlier, which are ACIs and ARBs, and the fact that you can't give all the immunosuppressives. So you're going to have to touch all those angles, because I feel like they're looking for the ideal, and at the same time, they're also looking for you to also chip in some of those things, because they can't just put all those extra things inside there without them expecting you to discuss it or have something to do with it. Yeah. So because of our time, I'll just stop there. Thank you.
Thank you very much, sir. I'll make the adjustments to the slides.
Your slides are fine. It's just to add the fact that she's pregnant, and then those things that you can't do in pregnancy, and the fact that what you're aiming for is to prevent progression to the advanced stage and kidney failure.
Okay, sir. Thank you very much.
All right.
Thank you so much, Chief Chito. The presenter, Dr. Tema Kumo, thank you. That was quite eloquent. Thank you so much. We've really gone beyond our time, 16 minutes past 8, at least 50% of the class has left the discussion already. So please, the first presenter, Dr. John, thank you for a wonderful presentation. All our facilitators, thank you. All our participants, thank you for coming to the class. We'll have to close the class now. Tomorrow is dissertation by 7 a.m. Please keep to time and come. I think that's also what I want to say. Thank you, everyone, for coming. We appreciate your presence, the facilitators. We appreciate your presence, the participants. We appreciate your presence. Chief Banks, I don't know if you are still in the class. Chief Banksy? Okay. Chief Chitu, please close the class, sir.
Okay. All right. Thank you, everyone, for a wonderful discussion. Yes, tomorrow is our dissertation day. Please, tomorrow we're keeping to time. So presenters, please, let's ensure that we can present what we have in 20 minutes, and then we review and close. 2 of our reviewers coming tomorrow are pressed for time. So please, we are going to have to move really fast. Okay. So I wish everybody a wonderful day, and I hope to see all of you tomorrow. Thank you. All right, Dr. Christabel, I'm done.